This presentation is on a walking program to decrease loneliness and depression. My name is Yvonne Bossert. I have been a registered nurse for 35 years now. It's hard to believe. I've spent the majority of my career working with cancer patients, which I always felt was a privilege and an honor to be a part of their journey. For the last 10 years I was in the clinic, I was working as the director of a research program where we were doing phase 1, phase 2, and phase 3 clinical trials. And toward the end of that, I was feeling completely exhausted and burned out. And I made a very drastic decision to go in a completely different direction with my career and took a position as a nurse educator with a pharmaceutical company. So I currently work for this company and I educate providers and support staff on hematologic malignancies, and I also provide support for our product portfolio. That being said, when 2020 hit, I struggled with guilt about being away from the clinic and away from the hospital setting and wondered how I could continue to make an impact. And I realized that after the death of my brother, that what I wanted to do was look at nursing from a broader perspective, given that 10,000 foot view of what nursing is and how it can impact not just the health of one individual, but of whole populations. And I made the decision to return and get my DNP. I have a very large family. I have 5 children. 3 of them are married. Now they're all grown and out of the house. And I've also been blessed with 6 grandchildren, and they take up the majority of my spare time when I'm not in school and not working. One of the things that's interested me for a long time has been mental health specifically, and many of the first project proposals that I had were centered on mental health, and particularly the mental health of the elderly, because I felt like that was an extremely vulnerable population. And out of that, and a discussion that I had with Dr. Love, when one of my project proposals was deemed not suitable by my company, I had to rethink what I was going to do. And I hit upon walking and the problems of loneliness. Now, more than 1/3 of the adults in the United States suffer from loneliness. Now, Cigna, the healthcare company, sent out a survey to their subscribers in 2018 and found that more than 43% of the respondents experienced some degree of loneliness. When that survey was repeated in 2021, that number affected more than 60% of the people responding to that survey. This is of epidemic proportions here in the United States. And we know it's a problem, but it isn't isolated just to the United States. This is a worldwide program. In fact, both Japan and the United Kingdom have ministers of loneliness to look at the problem and search for interventions. But as Dr. Hollis likes to say, so what? Why does this matter? We all feel lonely once in a while, but it does matter because there are very real consequences of loneliness, including an increase in heart disease, functional decline, hypertension, hyperlipidemia, an increase in BMI, inflammatory cytokine increase, which we know can thereby lead to autoimmune disorders and cancers, and global health deterioration. It can also lead to early onset dementia, personality disorders, suicidal ideation, and depression. In fact, what I found in the literature is that depression and loneliness are so closely intertwined as to be almost indistinguishable from one another. It can also lead to early mortality. One longitudinal study showed that loneliness was associated with a decrease in total life expectancy of 3.6 years, and this was all-cause mortality. The study also found that it was associated with an unhealthy lifestyle, a decrease in overall quality of life, and multiple comorbidities. Because it has such serious consequences, it's something that needs to be screened for, and we need to identify appropriate interventions. In fact, some have proposed that loneliness should become one of the social determinants of health. There are a number of screening tools available. One is the De Jong-Garifold screening tool, and I probably butchered that name, but it's an 11-item questionnaire. But the one that's used most commonly, particularly here in the United States, is the UCLA Loneliness Scale. Now, this original scale was a 20-item questionnaire, but it's gone through a number of tests over the years for psychometric testing, for validity and reliability of shorter versions of the form, including an 8-item questionnaire, a 6, and a 3-item pre-screen questionnaire. I chose the 6-item questionnaire for this project because it was shorter, it was more appropriate for a community-based project, and was less of a burden on the participants. Now, Leach in her DNP project used the 3-item questionnaire to assess elderly patients in a home healthcare setting. And then if they had a high score, they were offered a menu of items to hopefully decrease loneliness. And these included a loneliness support line, humor, music, scripture reading, and reminiscence. And she did indeed find a decrease in the scores of the ULS-3 for that particular project. Now, screening for depression is something that's done routinely in doctors' offices and clinics, and this is a 9-item questionnaire. However, there is a 2-item questionnaire that's been psychometrically tested and is valid and reliable as a first look at whether or not patients are at risk for depression. I also incorporated this because of the close tie between depression and loneliness, and these were measured both pre and post intervention. Now, within the literature, I found a number of different interventions, including the use of social media, crafting, support groups, mindfulness, journaling, mentoring programs, and exercise. And what I found was the more successful programs involve socialization and group interaction. I chose the American Heart Association walking program because this is an established evidence-based program designed for cardiac patients. However, it was easily implemented for the purposes of this project due to its structure, its clearly outlined events, and the suitability for group walking, and the time frame in which to complete the walking program. So the purpose of this project really was to determine if walking as a group could positively impact loneliness. The PICO question, therefore, is, will the use of the American Heart Association 6-week beginner walking program decrease the incidence of loneliness and depression in adults at Trinity Episcopal Church in Folsom, California, as measured by the UCLA Loneliness Scale 6 and the Patient Health Questionnaire 2, pre and post intervention? The methods I used included identifying an appropriate framework. In fact, I found the implementation framework logic model, which is specifically designed for community-based programs. I then had my screening tools, the ULS-6 and the PHQ-2. My site selection was Trinity Episcopal Church. I'm a member there. They were agreeable to using the site, not only as a meeting place for the walking program, but also to recruit participants from. I chose the American Heart Association walking program. As I stated previously, it's amenable to this particular project for community because it sets expectations on what they were going to do each day that they walk. Now, the AHA has 2 different walking programs. One was a 4-week walking program that is for intermediate walkers. I chose the 6-week program because it was a beginner walking program and was accessible to almost everyone who wanted to participate. I recruited volunteers to lead the walking program because I'm employed full-time and wasn't available Monday through Thursday to walk with the participants. Once I did all that, I set my dates and began recruitment of participants in the month of August, and I used flyers, newsletters, and informational sessions. Pre-intervention, anyone who was interested in participating was asked to sign a general release of liability, and this released both the university and the church of any liability in the event of an injury that would take place during the walking program. Once they signed that release of liability, then everyone was given an anonymized demographic form, as well as the ULS 6 and PHQ 2. Now, those forms were numbered, and those numbers carried through to the end of the study for pre and post-intervention comparison purposes. The demographic form included information on sex, general age range, their work status, their living situation, their marital status. I wanted to find out, were they with people and interacting with people on a daily basis? That was the whole idea behind the demographics that I collected. Then the intervention, as mentioned previously, was for 6 weeks, and post-intervention, they were given the same numbered form to complete. Once again, it was anonymized, the ULS 6 and the PHQ 2, but what I didn't anticipate were the unsolicited comments that were written on the bottom of the forms, and I will share those with you. Now, there was no change in the PHQ 2 scores, essentially, except for participant number 2. She had a modest change to hers, but the rest of them were low, except for participant number 4, and her PHQ-2 scores were actually quite high. This would be someone that if you saw her in a clinic, you would refer her to the PHQ-9 to further evaluate for levels of depression. There was a numerical improvement in the ULS 6 scores. Now, participants number 1 and 2 had the lowest loneliness scores, but they also corresponded with low depression scores. And also, it's interesting to note that both of these participants were married and lived with their respective spouses. Now, participant number 3 and 4 had higher loneliness scores, and both of them were divorced and lived alone. And I don't know if there was a correlation there, but I thought that was interesting to note. Now, there was an issue with question number 2. The answers or the responses weren't always consistent with what the other responses were in the survey. And I think it's because on the ULS 6, that's the only positive question on that survey. All of the rest of them are negative, and as a result, that question is reverse scored. And I'm wondering if they didn't read the item carefully or they responded too quickly. Now, when I did the statistical analysis, you can see that it was not significant. The p-value, in fact, was 0.0989, and although you didn't see a statistically significant difference in pre and post-intervention scores, what was really telling were the comments that were written on the bottom of this final surveys. One participant said, "I rarely walk with friends, but this experience has taught me the benefit and joy of interacting while walking." While another said, "I would do this again if it were available here. I enjoyed getting to know new people." But the one that really touched me and really spoke to the value of a group walking program was the final respondent. And that was, "This gave me a reason to get out of bed every day." And this was from participant number 4, who had the highest loneliness scores and also had the highest depression scores. Now, there were some limitations with this, as there are with all projects and all research. It was a very small sample size. There were just 4 people who participated. And because it was from a single site, there was a lack of diversity. All of them were upper middle class. They all lived in their own homes. It was a very homogeneous group of people. They were all white, but it is reflective of the parish. And all of them were over the age of 65. Which isn't surprising because it's difficult to commit to a daily walk at 10 a.m. in the morning. The weather was a bit of an issue. The heat was pretty hard to manage on some of the days, even though it was in September and part of October. And there was an issue with smoke one day where the air quality index was quite high, and so we actually had to cancel the walk that day. There was some volunteer dropout, but I had already identified backups just in case, and it was a good thing I had done that because somebody else was able to step in and cover that when someone dropped out. The American Heart Association walking program really provided the structure that I needed for this project. It very clearly outlines what the participants are to do, how long they would walk, and the intensity of the walk. So it not only set expectations for the participants, but also for the volunteers. Everyone knew exactly how long it would take each day they met. Also having that consistent time, days of the week, and an exact meeting place. The church property is quite large, and so they identified quickly that there was one particular tree where they would meet that was easy for them to locate. And there was also significant camaraderie among the participants, and throughout it, they were able to share stories about themselves and about travels, family, prior work experience, and they even exchanged telephone numbers. So thinking about sustainability, this really is a low cost or no cost intervention that's accessible to most people. It could be implemented almost anywhere at schools, churches, civic organizations, and parks and recreation departments. This is something, though, that the community would need to be made aware of. And so what do? You create flyers that are posted where people go regularly, places like pharmacies, clinics, doctor's offices, grocery stores, places like that where people gather on a regular basis. The information also needs to be shared with providers, particularly family practice providers and internal medicine and gerontologists. And although this protocol was open, or the project was open to anyone over the age of 18, the participants were all over the age of 65, so it's also important to share the information with gerontologists. And I do intend to publish, and I have the submission package ready to go. And for that, and it is the American Gerontologic Society Journal. I can get that out. Loneliness is significant, and it's a huge problem, and we talked about the consequences of that, and as a result, we need to begin screening, and that's something particularly advanced practice providers need to look at this as an issue. Now, Humana, I do not endorse them, but they do have a loneliness toolkit that I found online, and it's for providers, and this includes the ULS-3, that very shortened version of the UCLA loneliness scale, and they recommend that it be used as part of the annual physical exam or during a routine office visit. If patients score high, they recommend that they be referred to mental health services, but they offer no other specific recommendations for intervention. Future research really should be focused on adults with high loneliness or depression screening scores, applying the walking intervention, and then measuring those scores post-intervention to see if there is a true verifiable benefit of walking programs to decrease loneliness and depression. There are larger implications of walking programs really are of benefit. And thinking about this, how can we encourage walking if safety is an issue? So we need to think about sidewalks, lighting, crime rates, and offer alternatives, and getting people to places where they can meet and walk together as a group. And what about inclement weather? Can you find places that are indoors, such as school gymnasiums or indoor shopping malls? The positive comments were very encouraging to me and gave me at least an initial peek into the benefit of a walking program in a community setting. There was an increase in socialization for participants, and I think there's value in and accessibility of community-based walking programs. On a personal note, I will say this has taught me perseverance and the challenges in overcoming obstacles along the way to complete my DNP program. But ultimately, it's taught me the value of community. Dorothy Day, who started Catholic Charities, her autobiography was titled The Long Loneliness. And she says in there, we have all known the long loneliness. And we have learned that the only solution is love, and that love comes with community. Loneliness is a near universal phenomenon. It is no different than pain, thirst, and hunger in telling us we have a need. And we need to address that and look at that as one of those social determinants of health. And I hope that by publishing this and relaying this information to others, that they will see the significance of loneliness and begin screening for it, and hopefully find interventions that might include a community-based walking program. I do want to acknowledge Dr. Hollis for her guidance, her wisdom, and for keeping me in the program when I swore I was going to quit. I also want to thank you, Dr. Wyckoff, for your encouragement, your help in overcoming some of the obstacles, and your insistence on scholarly intent. And I want to thank my family, most of all, their love and support. I could not have gotten through this without them. And I want to thank Dr. Marie Christine Seitz, one of my coworkers, for listening to this presentation over and over and over again and making recommendations. And also, I want to thank my mother. She is also a nurse and a role model and a sounding board for me, and my biggest cheerleader and my greatest fan. So thank you.
Thank you, Yvonne. Great presentation.
Thank you.
And really, to use the words in the chat, absolutely groundbreaking. I would like to open the first question to Dr. Rush, please.
Yeah, that was Yvonne, first of all, just an incredible project and presentation. And that was actually my comment, that this is groundbreaking. And I'm going to have to sit and kind of stew on this a little bit for a while, because I'm not exactly sure why this is just really speaking to me. And I think it's because, like you said, it's just a universal part of life, right? Yeah. Loneliness, happiness, hunger, thirst, all of that. And I'm sitting here racking my brain. I have never, ever, ever been asked by a healthcare provider, are you lonely? Yeah. They certainly say, do you feel safe in your own home? Those questions that I don't think they even really are asking for any real reason except to check a box, right? Yeah. And this is such a huge, huge thing that is, on one hand, seems so simple, right? So why aren't we doing it? So I think this is just an incredible project, and raising this awareness is just fantastic. So congratulations, really good job.
Thank you very much. As you can tell, I was very passionate about this topic.
You should be. You should be. It's great.
Thank you.
Dr. Stacy, I saw your hand up.
Yeah, Steve sort of stole something by thunder, because it's the very same thing. I love this project. I'm passionate about walking within social groups. I joined a group last year, and I cannot express how much they've elevated my mood, and I sleep better, I think better. I was able to finish my DNP project because of the support that I got from this walking group. It was, I really, really love this project. And again, I've never been asked about my loneliness. I mean, and we can work around a lot of people and still be lonely. And so hats off, and I do hope that you publish. This is, I never would have thought about it. This is just phenomenal work.
Well,
and I hope that your church is able to continue with their walk group.
Yes, they are. Actually, they're going to set this up. I shared this with the rector, and Father Todd said, oh, well, we need to continue this. He said, I think we just need to put it on the calendar and make this a routine thing. He said, maybe not 4 days a week, but at least 3 days a week, where people could all meet and know that this is something that's happening. And they do have, because like a lot of churches, it's mostly retired people, so they do have people who can lead the group and have volunteered to spearhead this. But it's something I also want to share with other churches in the area, because it's something that's not just limited to Trinity Episcopal. It can be done at any of the churches in the area. Yeah.
Thank you. Dr. Fermento.
Thank you. Yvonne, outstanding work. I echo their faculty members. And I think, as I mentioned earlier, when I was commenting on Krista's presentation, I work with the geriatric population, and I never even thought to ask about loneliness. I think I talk about, increasing, social support and engagement and social interaction only when addressing depression. And, I think that one of the reasons perhaps that loneliness is not asked about or addressed is because we're not really sure as providers how to what to recommend, or what is an evidence-based intervention that will be meaningful. And so if you don't want to open the box if you don't have a response, or there's no you don't know what to say, other than go and hang out with your family or go to the community center or call a friend, so it's really, this is wonderful. And I was just talking to our clinic director last week about having a walking and talking group, which is, but I didn't know that the American Heart Association has an actual evidence-based walking program set forth. So I truly hope that you publish, and I hope that this is sustainable within your church, and that we can start to develop this type of social support, for all populations, but particularly the geriatrics. And I think that loneliness and isolation has really come to light after the pandemic, and for across all social and age groups and social demographics. So excellent work. Excellent.
Thank you so much.
Yvonne, one thing that I heard you say, can you close the loop on what we would do with abnormal PHQ screening? Is one thing we talked about.
For the PHQ-2 screen, it's always been recommended that if they have a high screening score, they should go on to complete the PHQ-9. And if the person scores high on the PHQ-9, then there are referrals to mental health, because this is someone who has significant depression. And it was interesting because the volunteer who started out walking with the participants expressed concerns about this one participant who had the very high PHQ-2 score and also had the highest loneliness scores. And indeed, one of the days when I did walk with the participants, I really had a sense of that from this person. And, the nurse in me wanted to make recommendations, but of course I didn't, because that wasn't my role in this setting. But, I think because those two are closely associated, that even though she had a high loneliness score, it did go down some post-intervention. So that's encouraging. Her depression scores didn't change, but her loneliness score did. Yeah.
Do we have other questions for Yvonne? If not, I would like to congratulate you, Yvonne, on your project. And I would like to close this session with Yvonne's presentation. Thank you so much.
Thank you.